Dr. Saad, and much thanks to you for your great efforts and the Mega Online Academy that we actually learn a lot from this. It's my honor to introduce our great professor, Dr. Raafat Abdel-Azim. Dr. Raafat Abdel-Azim is a remarkable professor of anesthesia, surgical intensive care, and pain management at Ain Shams University. Dr. Raafat has a long list of lectures about mechanical ventilation that can be a reference for you, for your practice in anesthesia and intensive care. So I advise you deeply to listen carefully to Dr. Raafat's lecture and to the previous lectures as well. Let's begin with our professor, Dr. Raafat Abdel-Azim. The mic is yours, and thank you so much.
Thank you, Dr. Saad. Thank you, Dr. Mohammed Yassin. I am very happy to meet you. I know that you are giving lectures. I'm following some of them. It's very nice to meet you. Thank you.
Thank you.
Welcome. Welcome.
Welcome.
Regarding my previous lectures, I will give only a few words about the summary of parts 1 to 4. And in part 1, now everybody knows types of anesthesia ventilators and what is respiratory cycle, what is the relationship of the ventilator to the breathing system. This is very important. And the flow arrangement of basic two-gas anesthesia machine, either oxygen air or oxygen nitrous oxide. What is meant by ascending bellows ventilators, the bellows that is going up during expiration, and what are the 4 valves controlling the operation of the anesthesia ventilators, what is fresh gas flow, and now we know that we have 3 types of gases, that is patient's gas, the driving gas, and the fresh gas. And we know now what is flowing into the inspiratory limb is the 2 components, what is coming from the ventilator and part of the fresh gas that is delivered during inspiratory time only. And we know the control of how to control the parameters of ventilation or the sets or settings of the ventilator or the preset values. The inspiratory flow rate, how to adjust and what is its value, and the ventilator classification, and what is the interaction between ventilator and the breathing circuits, whether with loss of part of tidal volume due to circuit compliance or addition to the preset value by the fresh gas flow, and how to avoid this by use of any technology of fresh gas flow independent ventilation, either by fresh gas compensation, or fresh gas decoupling, or other methods. And in part 3, we know now the ventilation cycle, the components of the ventilation cycle, what is controlled ventilation that is for anesthesia ventilators, because in ICU ventilators, we have a lot of modes that we are not, it is beyond the scope of our lectures. We are talking only about anesthesia ventilators. For anesthesia, patients should be paralyzed, and the ventilation should be, if we control the ventilation, should be controlled either by volume or pressure. And I described the airway pressure changes in volume controlled ventilation and pressure controlled ventilation, and how resistance and compliance affect the peak inspiratory and the plateau pressure according to the reason of this increase, either resistance or compliance, and how can we differentiate between each part. I described what is time constant and its importance in clinical practice by increasing or decreasing the inspiratory time according to the component of change, either in resistance or compliance. I described the pressure change during volume controlled and volume changes during pressure controlled ventilation. And in part 4 last time, I described the ventilator display, either numerical or graphical. And about the graphical display, there are types of scalars and loops. I described in detail each one. Regarding the loops, we have 3 types, and I described already. How the spontaneous breathing is displayed and how the display appears for volume controlled and pressure controlled ventilation. Also, regarding the goals of pulmonary ventilation for adequate minute volume for having the desired CO2, and why we increase or decrease the and how we calculate the minute volume, and why to increase or decrease it. Changing of the ventilator settings, each one, if we change, how does it affect the other settings? And we should be aware of these changes and not only changing a setting without being aware of its effects on the others. I described what is inverse ratio ventilation and what is the value of having an inspiratory pause. Either it is naturally occurring, or we can create or control its duration regarding the total inspiratory time. Today, I will give a hint about how to set the alarms in a mechanical ventilated patient. Alarms in modern ventilators are prioritized. We have to check that alarm limits are enabled. Alarm is enabled, visual and auditory alarm, and its limits are adjusted according to each patient. If we change the settings for one patient, we have to readjust in the next one, and so on. So the alarms, most of the alarms are readjusting for each case. Check if that the alarms are enabled, the alarm limits are adjusted and functioning. The alarm system detects most of the problems, but not all. Alarm audibility or volume should be tested and adjusted. We know that sometimes the surgeon, especially the plastic surgeons, like to have music, and sometimes they ask to disable the alarms. Please don't do. Silencing of the alarm or the audible alarms, because foreign alarms that are annoying, should be discouraged. We have alarms for inspired oxygen, high and low. Any alarm limits has its upper and lower limits. For oxygen, we have the high limits usually adjusted at 100%, unless lower values are intended, like ventilating neonates, especially preterm. We don't like to give 100%. Of course, everybody knows that. And we have to adjust the limit to 50% or 60% according to the case. Low alarm limits are adjusted and can be user adjustable, or in modern ventilators, the default is 30%. Of course, we know that air contains 21% of oxygen, and under anesthesia, the requirements of oxygen are higher than the normal situation. So under anesthesia, we have to adjust, or better to adjust the lower limit to 30%, not less than this value. The peak inspiratory pressure, the high and low, are adjusted like as we will see. You look at the red lines. The upper one is the higher limit, and there should be a lower limit alarm. The lower alarm is usually neglected or ignored by most of us. Everybody knows how to adjust the high. The higher limit, the default setting is 40 centimeter water, and we can adjust or readjust according to the condition, like having high compliance or low compliance, or possibility of having emphysematous bulletary rupture, so we will decrease. Regarding the low limit, we should know the fact that if not adjusted, it may not detect some problems, as will be seen in the next slides. The ability to set high pressure limit, usually in the new ventilators, it is adjusted, automatically adjusted at 40, but we can change. The ability to set the high pressure limit values of 60 or more may be necessary to permit adequate ventilation of patients who have low compliance or stiff lung. For very severe cases of stiff lung, the pressure may exceed 40 under anesthesia. So we have to have something to stop this limitation, or the alarms that will be continuously activated. So we need to increase a bit. In some older models of ventilators, it is not user adjustable like the new one. In older ventilators, it is adjusted as 65 centimeter water, very old ventilators. And this one is too high to detect an otherwise harmful high pressure. So better to avoid using older models because of this. It's one of the reasons to stop using these ventilators. Regarding the low pressure alarm, it is the low pressure alarm of the peak inspiratory pressure. As you see in the graph, we need to keep the values of upper alarm limit and lower alarm limit ranging above and below the peak inspiratory pressure. Regarding the low pressure, it should be adjusted just below the peak inspiratory pressure for each patient. Now, we'll not adjust the low pressure alarm for all patients. It is only for each patient. So you start ventilating the patient, you intubate the patient, start surgery, and check what is the peak inspiratory pressure of this patient. If it is, for example, 20, you set the low pressure alarm at 15 to 18 centimeter water, 2 to 5 centimeter water below the peak inspiratory pressure of this individual patient. Because this will trigger the problem if the alarm will be triggered if there is small leak, small circuit leak or partial disconnection will go undetected if the low pressure alarm is not adjusted properly. If it is too low or if it is not adjusted, if it is zero, it will not detect small leaks or partial disconnection. Examples of small leaks or partial disconnection, like if ventilating a patient undergoing macrolaryngeal surgery, the small tube, the small sized tube, for example, 4 or 4.5, if the tube comes out of the trachea and it is in the oropharynx, and it is still connected to the Y-piece and the ventilator and the circuit and the ventilator, the positive pressure ventilation will give a positive wave, even if the tube is not in the trachea. This positive wave is due to the small tube, like also ventilating neonates. The small tube will give positive pressure, even if it is not in the trachea, but it is still connected to the ventilator. So the peak pressure will be positive, but below the usual value as will be seen in the next one. Here, the upper graph shows a properly adjusted low limit alarm of the peak inspiratory pressure. On the left side of the upper graph, the usual curve, but the right side one shows partial disconnection. With partial disconnection, the peak pressure is above zero, but if it is below the low limit of the alarm, it will be it will give audible alarm because we adjusted properly 2 to 5 centimeter water below the peak pressure. Go to the lower graph. If it is much away from the recommended value of 2 to 5 centimeter water below the peak, here, for example, it is away for example, 10 centimeter water below the peak. So if the positive pressure is 5, 6 centimeter water, and it is above the threshold, it will not be activated. It will be like that one between the upper and lower. Here in the low graph, it is not properly adjusted, and it will not give alarm if there is partial disconnection. The low pressure alarm is automatically enabled using the new anesthesia workstations or anesthesia ventilators. It is automatically adjusted. Not all the ventilators are like that. We have some other types, like it can be bracketed automatically to the existence. So the ventilator will check the peak and of this patient. And when we apply what's called auto limits, if we press the button of auto limits, it will be adjusted automatically. Other user variable ventilators, all the ventilators, we can adjust it manually. In all the ventilators, we have preset values of low limits of peak and inspirator pressure alarm. For example, 8, 12, or 26 centimeter water, we cannot change. But how to manage this situation, we will see the peak and inspirator pressure of this patient and readjust, use 8, 12, or 26, whatever the values in this ventilator, use the one that is just below the peak and inspirator pressure of this patient. There is what's called continuing pressure alarm. The pressure is more than 10 centimeter water. خلاص, we finished what is about the low limit, high limit, and the low limit of peak and inspirator pressure. Now we are talking. Sorry for the internet connection that is unstable. There's another type of alarm that is continuing pressure alarm. Continuing pressure alarm will be activated if the peak and inspirator pressure is more than 10 centimeter water for more than 15 seconds. This means that the pressure is continuous. There is no intermittent increase or decrease. The causes of gradual increase in circuit pressure are malfunction of the ventilator pressure relief valve and malfunction of the waste gas scavenging system. If it is occluded, it will lead to an increase in pressure. And this depends on how the fresh gas flow is adjusted. If it is high, this will be seen soon. That's called subatmospheric pressure alarm. If the pressure is less than negative 10 centimeter water, like for spontaneously breathing this patient forcefully, this will lead to the pressure alarm. The very low pressure will lead to negative pressure pulmonary edema. It may be a result of spontaneous effort with the use of controlled ventilation. For a spontaneously breathing patient under anesthesia, if we intend to use controlled ventilation, we have to paralyze the patient. If we are going to awaken the patient because the surgery has finished or near finishing the procedure, use manual assisted ventilation. If the patient starts to breathe spontaneously, either to give muscle relaxant, or if you intend to awaken the patient, start to use manual ventilation or shift to SIMV, as we will see later, or any form of pressure spontaneous breathing support if it is available, to have the valves functioning for this type of ventilation. Ventilator allowing the patient to breathe spontaneously. The malfunction of the scavenging system also leads to subatmospheric pressure alarm. If it is active scavenging system, side stream sampling also, because it works like a suction. If the fresh gas flow is inadequate, if it is too low than the recommended value, or using a suction catheter during use of the ventilator into the airway, or suction during fiber optic or fiber scope using suction through its port. Another form of monitoring the patient under ventilation, that is the spirometry or volume monitoring. It monitors the tidal volume and the minute volume, and the sensor is located near the expiratory valve, and it is used to monitor the ventilation and the circuit integrity. If there is circuit disconnection, the low tidal volume alarm, if appropriately adjusted, it will be activated. As I said before, adjust the limits for each variable for each patient. If we have finished operation of an adult patient, and we are going to ventilate in the next case a child, so we have to readjust all alarms, that the tidal volume high low, the pressure high low, and so on. In some older ventilators, the low volume alarm limit threshold may be not user adjustable. It is a preset value. For example, at 80 milliliter, and of course this is no more used. Now we will go to the title of modes of pulmonary ventilation in anesthesia ventilators. Of course, in ICU ventilators, we have a lot of modes, and they are not used for the patient under anesthesia. As I said before, under anesthesia, we have two main modes: always controlled ventilation. The patient needs to be paralyzed, so we use volume controlled or pressure controlled ventilation. Now, if the patient needs another form, for example, when starting anesthesia or near the end of the operation, the patient is spontaneously breathing. As I said, we can see this on pressure time scalar or pressure time curve. Here is zero pressure over the atmospheric pressure, and with inspiration, the pressure is negative, reaching -1, -2, -3 centimeter water below the atmosphere. And for expiration, it is +1, +2, +3, according to the patient effort. In a spontaneously breathing patient, better to use a bag, reservoir bag, APL valve to manage the patient. But with start of ventilation should be paralyzed. This is the curve of pressure time during spontaneous breathing. We can apply CPAP, like for giving anesthesia to patients with low compliance, like obese patients for bariatric surgery, or patients with head down, or so on. We can, if the patient is spontaneous breathing, we can apply pressure all the time by just partially closing the APL valve. It's for spontaneous breathing using the reservoir bag and the APL valve, we will adjust it to be partially closed to give high value more than 0, and this is a continuous pressure during the whole respiratory cycle. The spontaneous breathing will be slightly below the set value for inspiration and slightly above the preset value during expiration. For intermittent post-pressure ventilation, as I said before, the end expiratory pressure may be 0, and we can apply PEEP, that is positive end expiratory pressure, if indicated to increase the functional residual capacity and to avoid hypoxia. This resembles CPAP, but CPAP is for spontaneously breathing patient, and PEEP is for mechanically ventilated patient. The pressure will be always positive. The mode of assisted ventilation is like that. The patient is spontaneously breathing, and the ventilator senses the patient's effort, and the patient effort is not sufficient, so the ventilator will give a stroke of mechanical ventilation to help the patient. This is exactly like if the patient is spontaneously breathing and we're not using the ventilator, using the reservoir bag and the APL valve, and we will put I will put my hand on the reservoir bag, sensing by my hand the patient's effort. If the patient starts to breathe, the bag will be partially collapsed, and I will augment this one by more collapsing or more squeezing the bag. Here, this is the situation if we use the ventilator in the mode of assisted ventilation. It will sense, it will help. If the patient is not, so this is assisted ventilation, and the patient will control the frequency and the timing. There is a hazard of hypoventilation if the patient effort is not sensed by the ventilator. If there is no effort, there will be no assistance. No. If the patient is hyperventilating, this hyperventilation will be more and more by the ventilator. So each one will be sensed and assisted. If it is more than usual breathing, the assistance will be more and more. If there is no effort, there is no backup in assisted ventilation. Most of the anesthesia ventilators don't have this mode of ventilation, but it is still there in some types of ventilators. The mode of assisted ventilation can be also applied with the use of CPAP. Another form of assistance is the assist control. In assisted ventilation only without assist control, if the patient breathes, the ventilator helps. It will give a stroke. If the patient doesn't breathe, there will be no assist. But in assist control ventilation, when the patient breathes, the ventilator will help. But if there is no spontaneous breathing, the ventilator will give a stroke, will give assistance in a minimum frequency that we adjust. So we start assist control ventilation to sense the patient effort. And if there is no patient effort, the ventilation will be exactly like controlled ventilation. So here the ventilator senses, here the ventilator senses that there is no patient effort, but it would be given according to the minimum frequencies that I adjusted. If the patient effort does not exist, the ventilator will give exactly controlled ventilation according to my settings. So we know now what is assisted and what is assist control. Most anesthesia ventilators don't provide assist or assist control ventilation, and you can use this manually. Under anesthesia, the conscious patients are more comfortable if they start to breathe with an assisted or assist control. But with controlled ventilation, the settings of the valves don't make the patient comfortable. If the patient starts to have spontaneous effort under anesthesia and the patient was on controlled ventilation, either volume control or pressure control, and still the operation is going on, you have to paralyze the patient to avoid this discomfort. Intermittent mandatory ventilation means the ventilator will give exactly like controlled ventilation, and the patient is allowed to breathe spontaneously, but there is no any relationship. The ventilator will not sense the patient effort. So the patient can spontaneously breathe and the ventilator will give, and they are not related to each other. This is intermittent mandatory ventilation. We adjust these values as volume and frequency, and the values of the patient are patient trigger or patient controlled, I mean, only by the patient. And the patient does not initiate the ventilator. Spontaneous values for tidal volume and frequency are by the patient. Spontaneous breathing is allowed, and there is ventilation support by intermittent mandatory ventilation. Because in this one, because there is no relationship between spontaneous and ventilator settings, if they meet together during expiration, the patient will be in asynchrony, and the patient there will be discomfort because the patient wants to expire, and there is inspiration, automatic inspiration. So this is not one causes dysentery or asynchrony or discomfort and should be avoided. How? By synchronization. It will be seen as the next one. Slide. Back again to intermittent mandatory ventilation. Like the assisted control, if there is no spontaneous breathing, the ventilation will be controlled. Now it is exactly like the graph of the controlled ventilation. There's no effort. So intermittent mandatory ventilation will be controlled ventilation if there is no patient spontaneous breathing. Now the synchronization is done by the use of what is called triggering window. If we choose to, if we select to ventilate the patient with SI, maybe synchronized intermittent mandatory ventilation, the triggering window will be open according to the rate. For example, if the rate is 10 per minute, so every 6 seconds, there will be a triggering window. Triggering window to sense the patient effort. If there is no effort and we adjust the rate to be 10, so if there is no effort, the stroke will begin. If there is inspiration, then expiration, then inspiration, then this is the time for the stroke. If there is inspiration, the stroke that before its time was after a fraction of a second, it will be given earlier to be synchronized with the patient inspiration. Instead of the red one at a time, like this one, the red one, its time was here. But because this occurred during the triggering window, the patient inspiration is going on, so it will be given earlier to be synchronized. So the blue one is the synchronized one. So here, this is mandatory. This is the spontaneous breathing, in yellow. Here, sensing. Here, synchronized mandatory ventilation. The red one will not be there. And again, sensing in the next ventilation. So briefly, this is a synchronized intermittent mandatory ventilation. It can be controlled by volume, the rate and volume, or rate and pressure. And pressure limit the peak. The peak is seen during volume control pressure. For pressure limitation, we have to use a preset value of pressure limitation so that we avoid having this peak by limitation of the maximum pressure like that. So the curve will be changed from the peaked one to the straight one because the preset value is reached and it will be continued throughout the inspiratory time. The one on the left side is the volume control, the pressure changes, the peaked graph, and the one on the right side, the pressure limitation. As I displayed before, the different forms of graphs for flow, for pressure, and for volume, and volume control ventilation. And the differences with the pressure control ventilation, volume control on the left side, pressure control on the right side. And we saw that, we know now that volume control ventilation is useful to maintain the tidal volume or the minute volume. But its disadvantages are like that if there is the constant flow rate, this one, constant flow may lead to high peak inspiratory pressure that is affected by pressure changes in circuit compliance and patient compliance and resistance. And this may lead to barotrauma if the pressure is not limited. So barotrauma is possible during controlled ventilation and uneven distribution of pulmonary gas. Pressure controlled ventilation will give us low pressure, low airway pressure because it is limited. So the incidence of barotrauma is less, and the distribution of pulmonary gas is uniform, and oxygenation is better during pressure controlled ventilation. But the disadvantage is that tidal volume can change as the patient's lung compliance is changing. So minute volume is not necessarily maintained. If I am ventilating a patient with pressure controlled ventilation, here the airway pressure is, and the compliance changes, like, for example, the patient develops pulmonary edema, and I used pressure controlled ventilation, and I started to manage the patients with medications, and the situation improved. The patient's improvement will lead to improvement of compliance. So when we adjusted the pressure control to give a certain tidal volume according to pressure that I have limited or adjusted, with the patient's improvement in the condition, the compliance will be high, and the pressure will not be reached, and the tidal volume will be much higher because of this condition. And the reverse also occurs. If any problem occurs during ventilation, pressure control, that leads to changes in airway pressure than the set value. So if the pressure is reached quickly, the volume will be less. So volume can be changed according to the compliance. And we have to monitor the tidal volume all the time because of the possible change in compliance or resistance. To avoid the disadvantages of each one, we have a new form of ventilation that's called pressure regulated volume controlled or pressure regulated volume guaranteed. That is, we adjust the required tidal volume, but the changes in the patient's pressure will be sensed by the ventilator. The microprocessor of the ventilator will do the operation, will do the function. We started to use this form of ventilation in neonates and pediatric because the changes in volume or pressure are more important in this group of population. Recognition that the volume, not the pressure, is the key factor in ventilation-induced lung injury leads to development of this mode. It combines advantages of pressure-limited ventilation with the ability to deliver more constant tidal volume. As I said, with pressure limitation and the pressure controlled ventilation, there will be changes in the tidal volume by increase or decrease in the circuit, in the patient's changes in patient compliance and resistance. To avoid these changes, the pressure controlled regulated volume control is used. The breath valves are the tidal volume, the frequency, and inspiratory time directly applied or using our change the IA ratio to have it known. And PEEP also can be applied, of course. The ventilator initially performs a test breath sequence. So when I start to use pressure controlled ventilation, if I was using in this patient another form, the information are stored in the ventilator memory. It will sense it. But if I start immediately without having previously applied to this patient during the operation another form, if I start to use this mode of ventilation, it will undergo a test breath sequence. This test breath sequence measures the compliance of this patient, and subsequent adjustments in pressure are made on the basis of these measurements to give the desired tidal volume. So I adjust the ventilator settings for tidal volume, frequency, and inspiratory time. The tidal volume will be given and will be assured, but the pressure changes are first tested, and the flow will be adjusted by the ventilator to give the desired tidal volume without having hazard of increase or decrease. This is a graph enduring pressure regulated volume control ventilation regarding the airway, the flow, and volume. Here you see the changes in airway pressure and changes in volume, but almost the tidal volume is kept constant. This is enough for the modes. Regarding the hazard of ventilators, enough for the modes of ventilation during anesthesia, use of anesthesia ventilators. But of course, as I said, and I explained before, in lectures for patients in ICU, there is much more modes of ventilation than the limited modes during anesthesia ventilation. Other ventilators are, everybody knows why apnea due to failure of the ventilator, not switching on, disconnection, obstruction of the respiratory gas pathway, ventilator failure, wrong settings. Hypoventilation can also occur due to circuit leakage or incompetent spill valve or open APL valve only during ventilation using the old ventilators, like as I explained in for Pellon Nuffeld, I have to close the APL valve. But in all new ventilators, never mind about the APL valve too, because it is already isolated, doesn't need manipulation. So this one is only for the old ventilators. Driving gas leak, improper settings, ventilator limitation at high pressure, airway pressure. There is possible leaks at the, here are the possible disconnection areas, and the most common here is at the Y piece, or the dashed areas are for possible disconnection. Regarding if there is old bellows and it is injured, if there is injury or leak in the bellows, the high driving pressure will lead to high pressure in the breathing circuit and the high pressure inside the bellows, because this driving pressure is higher than the patient's pressure or airway pressure. So there will be dilution of gases inside the patient's bellows, and there is high pressure leading to barotrauma. These are the causes of high pressure. In summary, we know now how the driving gas and patient gas don't mix. The ventilation cycle is controlled by flow, volume, pressure, and time. During inspirator phase, the airway pressure depends on resistance and compliance. And we know now the goals of mechanical ventilation are to provide adequate minute volume necessary to maintain the desired CO2 and to decrease side effects. And we know what is the desired CO2, either the normal value, or we can decrease or increase by changing the minute volume. Higher minute volume is associated with lower values of PCO2. And the modern anesthesia ventilators provide a range of ventilatory modes we know now well. The difference between the delivered tidal volume and the preset values depends on the circuit compliance and the fresh gas flow. And the gas flow independent of ventilation decreases the risk of barotrauma. And we know the hazards of ventilation. Thank you. This is enough for today. I have finished the presentations for anesthesia ventilators, and this is now for questions.
Thank you so much, Dr. Raafat Abdel-Azim, for your fruitful lecture. Actually, the lecture was so clear that we don't have any questions. So let me ask you, Dr. Raafat, about something to clarify. When you are talking about the alarm limits in the beginning of the lecture, so that you said that we can allow the maximum pressure to increase up to 60 to 65 centimeter H2O if the patient has a stiff lung or something like this.
Yes. So, I don't. I don't recommend that. It is this comment is present in the books and reviews, I don't recommend that. But if you have a stiff lung and if you use the pressure, the volume control ventilation, you will be faced with this problem. Volume control, the pressure is limited at 40, and the delivered tidal volume is reaching 100, and the preset value is 500. So you have to have some way of thinking to solve this problem. One of these solutions that I don't like, but it is written there. You can increase the limit for instead of being 40 to 50, 55. But of course, I will not do that.
So it is a rescue step until we find the definitive step to manage this situation.
Of course, yes.
Lastly, about the modes of mechanical ventilation, as you know, our dear professor, the modern anesthesia machines now contains nearly all the modern modes of ventilation. We still use the older versions. But the newer ventilators actually contains all of the modes that you clearly explained them. Thank you so much, Dr. Raafat.
Thank you very much
for your great lecture. Actually, we came to the last lecture that in the series of mechanical ventilation lectures presented by Dr. Raafat Abdel-Azim. We want to thank you so much. We want to thank Dr. Saad Mahdi. It was honorable and a pleasure for me to meet you, dear professor, today. And I hope that I will meet you in the real life, nearly, inshallah. Thanks for all attendees, and meet you in the next lectures, God willing, inshallah.
Thank you, Dr. Muhammad Yassin. Thank you very much. Nice to meet you. I'm very happy, really. I'm deeply touched with Dr. Saad Mahdi for his consistent constant effort and insistence to make this course more extensive course.